commercial support, the speakers and planners have disclosed no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity. If you're viewing online, the link will be listed in the chat section of the Zoom. And if you're watching after the fact, we will list it in the description section of the video. It is my pleasure to introduce Dr. Abbasi. She is in her 3rd year of internal medicine residency. She completed medical school in Pakistan and came to the United States to complete her internal medicine residency. Her area of interest is gastroenterology. Join me in welcoming Dr. Abbasi.
Thank you for the introduction, Jennifer. So as you know, I'm presenting my grand rounds today. My topic is obscure GI bleeding. So I would start off with the disclosures. So I do not have any financial disclosures, no conflict of interest for the materials presented in this presentation. So basically, the learning objectives for this presentation would be acute lower GI bleeding. We would be going through the terminology, some of the common causes of small bowel bleeding, and the therapeutic options. The main purpose is basically to review the recent ACG guidelines that were published in March 2023 regarding lower GI bleeding, which basically presented some of the risk stratification tools that could be used for these patients to quantify if they are at a higher risk of a hospital-based intervention versus a lower risk. And also we would go through anticoagulation, what are the most recent updates regarding that per ACG, some of the reversal agents that are used, and also the most recent testing and management strategies and updates regarding those in lower GI bleeding. So I would start off with the typical case. So this is a 67-year-old female. She has coronary artery disease, a very typical case that comes to the hospital. She's on aspirin. She's also on some NSAIDs for her osteoarthritis. She presents to you with hematochezia. She has had a prior endoscopy that was normal. She has also had a colonoscopy that was 3 years ago, and it was normal. She was hospitalized about a year ago, and she had similar complaints. She had the severe hematochezia. She was stabilized with some resuscitation, and then she had a colonoscopy within 24 hours of that hospital admission, which basically just showed some diverticulosis and some blood throughout the colon, but no specific bleeding source was identified in that colonoscopy. Now, she was discharged after the bleeding was subsided and no intervention was basically performed. And now she's presenting to you again a year later with similar complaints, which is bright red blood per rectum, hematochezia. She has dropped her hemoglobin by 2 grams, but she's hemodynamically stable. And there is like bright red blood per rectum on DRE. So what I want the audience to think about while we go through this talk is a couple of questions when you look at this case. So looking at this patient and how she presented, do you think she should undergo another colonoscopy? And if so, when would you like to time it? As in, would you like her to get it within the first 24 hours of this hospital admission versus a later colonoscopy? And is there any role of a CTA in this case? And lastly, how do we prevent the risk of rebleeding in her? So I will get back to this at the end of the presentation, and we'll go through these questions. Yes, Dr. Gross?
Just a clarifying question. When you say chronic NSAIDs, do you mean in addition to the aspirin?
Yes.
Okay.
I just
She stayed on that throughout these previous colonoscopies.
So lower GI bleeding and obscure GI bleeding. Lower GI bleeding, going back to anatomy, it's the bleeding which is distal to the ligament of Treats. So who knows where the ligament of Treats is attached? I didn't know. I had to look it up. Yeah. So second to third part of the duodenum, and it attaches back to the lumbar spine. So any bleeding that's distal to that would be considered a lower GI bleeding. Obscure GI bleeding is a term that is reserved for patients that have no identified source of bleeding after an upper and a lower GI evaluation. So that's when you call it obscure GI bleeding. And we'll go through some of the recent techniques or interventions that are now used to basically find out where the bleeding is coming from. And then obscure GI bleeding is a term that now ACG is only reserving when there is nothing identified with after the use of all of those investigation tools. So most of the cases of these obscure GI bleedings are accounted for small bowel bleeds. They are about 5 to 10% of all the patients that present with a lower GI bleeding. For the purpose of this presentation and for the most recent ACG guidelines in 2023, they are basically talking about, they are referring lower GI bleed to all the bleeds that are basically of a colorectal origin. So you'll see they'll talk about these recommendations and all, but this would be reserved for bright red blood per rectum, hematochezia, and a bleeding that's coming from the colon or the rectum. So basically just some epidemiology and trends regarding lower GI bleed. So as you can see in the figure on the top right, the cohorts for the lower GI bleed are kind of getting to a similar incidence rate as compared to an upper GI bleed. So basically in the United States in the year 2018, you had about roughly 272,000 patients, ED visits basically for patients that were coming in for lower GI bleed. And about 115,000 of these were admitted with lower GI bleed as their primary diagnosis. So a significant number of patients admitted with lower GI bleed. And as you can see on the top left corner picture, the cohorts for the lower GI bleed in terms of the risk of recurrence, they are kind of trickling up and trying to match up with the upper GI bleed cohorts. So the recurrence risk of bleeding is actually getting higher for patients admitted for lower GI bleed. So risk factors, we all know most of this. The most common risk factor is NSAID use. There was actually a study that was done in the United Kingdom where they looked at 200,000, they had 200,000 patients in their study, and they looked at all of these were new aspirin users. And what they saw is that the incidence of lower GI bleed in these patients were about 1.6 per 1,000 person years. So it's a significant higher risk of bleeding after you start a low dose aspirin to have a lower GI bleed. And then the same P2Y12 inhibitors, clopidogrels, anticoagulants, also a risk factor. Of course, we know warfarin. What is important here to see is that they did this study which was basically trying to compare the bleeding risk of dabigatran or rivaroxaban as compared to warfarin. But the overall bleeding risk was kind of similar between the two groups. If you compare dabigatran and rivaroxaban to warfarin, patients would bleed with a similar incidence in terms of lower GI bleeding. However, what they did notice was that, and this is a study which was done in Iceland actually, they had a patient population of about 2,500 people, where rivaroxaban was associated with a higher risk of lower GI bleed as compared to apixaban. So apixaban was considered to be a little bit less associated with GI bleeds as compared to rivaroxaban. Of course, if you're doing triple therapy or dual therapy with antiplatelets and DOACs, it's going to increase your risk of lower GI bleed, so 70 per 1,000 person years. And lastly, if you compare antiplatelets, DOACs do not increase the risk of new diverticular bleeds. And why I mentioned diverticular bleeds here is that it's the most common cause of lower GI bleeds. And we'll go through this in the upcoming slides. Another thing which I mentioned here is, for example, that you have a patient that you started let's say rivaroxaban, they had this new AFib, you started rivaroxaban, you send them home, they come back with GI bleed. That's very common and we see it very often. So what they saw in this study is that a lot of these patients, when they underwent colonoscopy, had underlying some sort of colorectal neoplasia. So it was seen, or it was at least recommended to do a screening colonoscopy if appropriate, if age appropriate, to have before you started DOACs in these populations. This data that I just mentioned, it is from a systematic trial and randomized control studies that were published in the Clinical Journal of Gastroenterology and Hepatology. So some of the basic etiologies, and all of these are, it's a wide cohort with like all the different causes that have very different origins and management algorithms. So most common being, as I said, the diverticular bleed accounting for 30 to 60% of the cases. Some of the other rare causes would be angiectasias, colorectal neoplasms, of course, being up top on the list, infectious colitis, IBD, some stercoral ulcers, radiation proctopathy. So all of these are like common causes for lower GI bleed. And as you can see in the picture too, they're referring to bleeding from the colon or the rectum in these guidelines. So just going through some risk stratification. This was one of the primary causes, one of the primary reasons of them coming up with these guidelines is that they were noticing a lot of people coming in with lower GI bleed and getting a colonoscopy. There were less frequent use of risk assessment tools. There are a lot of risk assessment tools that are used for upper GI bleed, the most common one being the Glasgow-Blatchford score. So it is a score that is validated and it is used for upper GI bleed. So it is so any person with like a Glasgow-Blatchford score of less than 1. So if that person comes in with, let's say, an upper GI bleed, like melena or hematemesis, they have a lower score. They can, and they're hemodynamically stable. Of course, they have a criteria of the score and how they calculate it. But that patient could be potentially discharged early with outpatient follow-up, versus who has a score of, let's say, more than 7, they would be a person who's at higher risk of like an inpatient endoscopic therapy. And then they were basically trying to come up with a score for a lower GI bleed as well. So this score, it's called the Oakland score, and it's basically, and they found this score after a study that was again done in the United Kingdom. This score basically takes into account multiple factors, including age, patient demographics, systolic blood pressure, hemoglobin, and all of these things. So basically, if your patient has a score of less than 8 or 8, you classify them as a low risk. So low risk patient can be discharged early, and early discharge, of course, translating to reduced healthcare cost and early discharge. Whereas if you have a score more than 8, you're going to go. Also, it helps because you're going to triage your patient to receive an early endoscopy, and this is going to improve outcomes like rebleeding and mortality. There are other scores too, like the NOBLAD score, the Birmingham score, but these are not validated yet. The reason why they think, part of the reason why we don't use these scores too often is they're not built into EMR, and they were thinking that if this is something to look into in future, if some of these could be like automatically pop up when the patient is admitted with a lower GI bleed, for the providers to be notified that, hey, this patient, even though they're bleeding, yes, in front of you, but they're still a low risk. And I'll go through some of the interventions that they see, like even if you were to have a patient that you're seeing in front of you bleeding, but they're hemodynamically stable, they're low risk, even if you go and you do an endoscopy or colonoscopy, that's not going to reduce rebleeding or mortality in the long run. Maybe you'll see something, you'll clip it or you'll cauterize it, but data suggests that you're not going to reduce their rebleeding risk or their mortality. So going through the diagnostic evaluation algorithm, so any small bowel bleed that's suspected, either it's overt or occult, you initially do an endoscopy. After the endoscopy, if it comes back negative, you're not able to identify any source of bleeding. You then have to know if the patient has any sort of obstruction or not. If they do not have an obstruction, and your patient is hemodynamically stable, they recommend that you do the video capsule endoscopy as the first line. And if that video capsule endoscopy is coming back to be negative, is then when you go on to further investigations like push enteroscopy or a single versus a double balloon enteroscopy, and also if it comes back positive, then depending where you find the source of bleeding, you'll see if you were to do like a push enteroscopy, and it could be either done from the upper or the lower GI tract. If, let's say, during this process, your patient was, the bleeding subsided on itself, you can stop at that point. You can do conservative measures like, iron supplementations, fluid resuscitation, and then maybe consider like an outpatient endoscopy or a colonoscopy. So any patient with lower GI bleed that comes in, of course, the first line diagnostic tool that we think about is a colonoscopy. As I said, it may not be required if your bleeding has subsided, if your patient most importantly had a recent colonoscopy, because what you're trying to rule out as the most dangerous etiology is, yes, an ulcer, but what you would be worried about not to miss would be a colorectal cancer. So if, like our typical case, as you saw in the beginning of this presentation, she had a very normal colonoscopy, which had some diverticulosis, but ruled out neoplasia. That was done 3 years ago. So if you've ruled out colorectal neoplasia and your patient has no more bleeding, it just subsided, then probably would hold off colonoscopy, at least inpatient during that admission. Yes, it is of high value because it's not just diagnostic, it's therapeutic too. Once you see something, you can do something about it while you're doing the colonoscopy. And as I said, the con would be that it's of unclear value given if they've had a normal colonoscopy recently. Likely you're not going to either see something, or even if you're going to see something, you're not going to reduce their rebleeding risk or mortality. So just reiterating the same things as ACG guidelines. So the patients admitted with lower GI bleed that requiring a colonoscopy, they recommend that you perform a non-emergent colonoscopy. So it is not recommended that you perform the colonoscopy, like let's say 24 hours versus 24 to 72 hours. That's what they compared. There were actually 2 randomized control trials. And they compared these 2 groups, and what they basically saw that if you were to do a colonoscopy within the first 24 hours, you, yes, will shorten their length of stay, but you're not going to make any difference to the recurrent bleeding risk, and you're not going to reduce mortality, and you're not going to reduce the readmission risk. So within the 24-hour colonoscopy was actually not that beneficial as compared to a colonoscopy within 24 to 72 hours. And then, as I said, if your patient has a most recent colonoscopy that was normal, that excluded colorectal neoplasia, then you probably can hold off. They can do a colonoscopy outpatient and then go from there. So CT angiography. How many of you have ordered a CT angiography for lower GI bleeding? And in how many of those times did you actually find something? Like that was actively like bleeding or extravasating blood or something?
Maybe once or twice.
Yeah. So they do now recommend CTA as the initial diagnostic test, but that's only when your patient is having a hemodynamically significant lower GI bleeding. So yes, you can do it. It's first line. The sensitivity is 90 to 92%, but you have to do it within the first 4 hours of them coming in with a lower GI bleed. That's hemodynamically significant, so their vitals have to be unstable, and you most likely find something. It is of very low yield if you've passed that timeline. And if you do find an extravasation on the CTA, then the next step would be to call IR for an angiography and embolization, and that also is time sensitive, so it should be within the first 4 hours of you getting the CTA. So at some of the centers where they are having such a patient and they are ordering a CTA, they would like alert IR that, hey, this is a patient coming in. We'll most likely, if we find something, we're going to require an IR-guided embolization. So that's something that they are doing. As I said, just the downside is, along with, if you're not doing it in a time-sensitive fashion, you can probably not find anything in it. And then also, it's going to require IV contrast. Another good thing about it is that it's very quick. So you're coming in, it's a very quick procedure. You're sending your patients in for the CTA, they get the images, and you find the cause real soon, as compared to if you were to prep them for a colonoscopy, and then they go through the prep, and then they go through the colonoscopy. But this is conditional for only these patients. So here is some CT angiography that they have seen. So this is just a typical non-con CT. So likely you're not seeing anything on this. And this is when you give them the dye, and you can see clearly the extravasation of the blood right here. That is actively bleeding. And this is a similar picture demonstrating in the coronal view the same as I just mentioned. So you've had a positive CTA. Now you're going to do an angiography, IR guided. So here is just a fluoroscopy guided embolization that they've shown here with the arrows where the bleeding is, and then they embolize it, and no further bleeding noted afterwards. Its success rates are actually really good. So now you have a patient. She was just having this lower GI bleed, acute. And she didn't qualify for the CTA. She wasn't like hemodynamically significant lower GI bleed. So what do you do then? So you call GI, and then you tell them, hey, she's having this bleeding. What do I do? So likely if the patient is hemodynamically stable, as I said, the first line is the capsule, video capsule endoscopy. It's actually really small, and you can see it's quite fancy when you break up the capsule like this. So it has this LED lights, it has the signals and everything that it transmits. It's a first-line procedure for upper and lower GI sources of bleeding. It's actually really small, so it's about 26 into 11 millimeters, and it can take pictures, like 2 pictures per frame as it goes along the GI tract. So once you give it to the patient, you can monitor them for 18 to 12 hours, and it can identify with a positive predictive value of 97% and a negative predictive value of like really high, so 83 to 100%. The limitations, though, of the capsule is that once it goes in, for some reason, because of the curvature of the small intestine, especially the initial part of it, you can basically miss proximal duodenal lesions. So that's one of the limitations of this capsule endoscopy. And then the other thing is that, yes, you find the bleeding, but you cannot do something about it at that point in time, versus an endoscopy where you go and you see something, you can fix it. So it's diagnostic, not therapeutic. Some of the other options that we don't get exposed to as much is a push enteroscopy. So how long is the small intestine? And again, I didn't know, I had to Google. It was back in medical school, a long time ago. Yeah. Yeah, something like that. What? Yeah. So how long is the small intestine? It's huge. It's very long. It's just curved, and it's about like 5. Because in order for us to like go through this, we would have to know how long it is and how deep we could go in with each of these interventions. So it's about 550 centimeters, and your large intestine is about 150 centimeters. So with the push enteroscopy, you can go in distal about 70 centimeters from your ligament of Treat. So below the duodenum, you can go all the way up to the 70 centimeters. So you can go to like proximal duodenum, and that's all. You cannot go beyond proximal duodenum with a push enteroscopy. Then comes like deep enteroscopies, which include single and double balloon. Basically, the reason of these balloons, other than doing interventions and then applying pressures at site of bleed, is that imagine that you have this endoscope that's long, and you're going in through the stomach, and then once you bypass the stomach, the small intestine is like very much curved, and it has a lot of curvatures and twists and turns. So it kind of anchors in the small intestine when you inflate those balloons, and it can kind of like, you can go through it much more easier and in a controlled way as compared to if you just have something that's just kind of moving with nothing anchoring down. So and this can be done, the deep enteroscopies could be done like upper endoscopies or versus like through the rectum. So if you were to go with an upper one, you will cover a distance of about 250 to 350 from the distal pylorus, so all the way to the proximal duodenum, the distal duodenum to the like large intestine you can go. And then if you're doing the rectal approach, you can basically almost cover all the colon. There is another one which is fairly recent, the spiral enteroscopy, which is just basically I have a picture here, but it's basically like spiral kind of elevations here on your distal end of the endoscope. And it's a 2-person procedure, so the nurse is kind of holding it, and then the gastroenterologist is looking, keeping the small intestine in the view for that. And then lastly, there is intraoperative enteroscopy. So this is by surgery. This is for patients that keep on coming in with like lower GI bleeds, no source identified on any of the above. And then finally, the surgery team goes in and they can do an enteroscopy either orally, rectally, or through an incision in the small intestine, like an enterotomy. But it has a higher mortality risk associated with it, and it's only reserved, as I said, for patients who've had multiple negative evaluations. Tagged red cell study is another diagnostic modality that's been out there. Now recently, with the data coming up, they are trying to stay away from it because it can very much vary with its localization of the site of bleeding. Especially if it's in the foregut and the small bowel, because essentially you're just tagging your red blood cells, giving it to the patient. Those tagged red blood cells can be uptaken by other organs too. And as you can see in the picture, that basically where you're seeing the bleeding, you see all of this red up here, or maybe dark up here too, but this is like normal where, those tagged red blood cells were taken up by the liver, which has higher metabolism rate. So it can obscure, it can actually like just hide the site of bleeding sometimes. And it's time consuming. It's like an image that you take and then you give it a few minutes and you take another image. So less likely to be first line or even second line. So massive small bowel bleeding versus subacute small bowel bleeding. This is kind of the same algorithm that we went that we went through before. So if you have a person that's coming in with a massive small bowel bleeding, you obviously first stabilize your patient. They are hemodynamically unstable with a massive bleed. As I said before, you can consider a CT angiography. If a CT angiography is negative, then move on to enteroscopies and things like that. If it's positive, of course, you're going to move to angiography and then embolization. If your patient is coming in with a subacute bleed, then probably consider a video capsule endoscopy or a CTA. If the video capsule endoscopy is positive, then what do? You find a source of bleeding. They're bleeding, let's say, from their proximal duodenum. Then you can consider a double balloon or a single balloon enteroscopy with an intervention that's needed, like clipping or embolization. So non-endoscopic therapies, which we all do commonly, is once your patient comes in with a GI bleed, you're of course going to give them IV iron or blood, depending on what they need. Every other day is the recommendation as compared to every day. Whatever you give them, they're only going to absorb 25% of it normally. So if it's like oral iron therapy, common side effects, we all know this, nausea, constipation, dark stools, which are often confused as my patient is continuing to have these dark stools or melena. I think they need an intervention. So always important to consider that if the dark stools are secondary to bleeding or versus they are secondary to oral iron therapy. And IV iron, same thing, 1 to 2 doses that you can give to your patients for a full therapy.
I just wanted to clarify terminology and nomenclature. So your talk is on obscure bleeding, right, which is a bleed that's not found on EGD or colonoscopy, correct? So that can comprise both an upper GI bleed or a lower GI bleed, seemingly so that the second third of the small intestine, like the trites, is the border for upper versus lower GI bleed.
Yes, so obscure GI bleeding means any bleeding that could be not found on upper or lower, like endoscopy or colonoscopy. So that would be obscure, where you could not find. But what we know is that majority of those cases are small bowel bleeds, end up being small bowel bleeds.
Yeah, so an obscure bleed could be either upper GI bleed or lower GI bleed.
Yes, it could be.
But usually, yeah.
Usually it's lower, yeah. Usually it's lower.
One more thing regarding if somebody is like taking oral iron tablets, so then you can expect melena. But if somebody is taking IV, it's going to be less likely because it's going direct to your blood, not to the GI gut. So just keep it.
Right. So these are some of the newer things that I also learned while going through this presentation. Is that we know mostly this, that if you see bleeding, you embolize it, you can, it can achieve effectiveness in 80 to 90% of the cases, the complications being like hematomas, some bowel infarction, thrombosis, pseudoaneurysms. But what else could we do besides these? Because the upper part is usually by GI. They are going to do that part. This is something that we could consider. This is usually, I know it is done by GI outpatient, but this is something that was new to me that could be done to prevent rebleeding. So you can do hormonal therapy, estrogen and progesterone. The way that they work is that they're gonna, they basically, when I was looking through this, it said that it can increase the number of circulating platelets and thereby reduce the bleeding time. Both of those hormones. And the other commonly seen medication that we do see is the octreotide somatostatin analog. So how does that work in reducing bleeding? Yes, it's a somatostatin analog, but how does that reduce bleeding? We see patients on drips for octreotide. We give them injectable octreotide. Do what? I didn't hear you. Splanchnic circulation, reduced splanchnic circulation? Okay, yeah. It also, yes, it reduces the blood flow, you're right. It reduces the blood flow in your splanchnic circulation. Along with that, it is also an inhibitor of angiogenesis. So it basically inhibits your vascular epithelial growth factor. So those are the two main mechanisms through which also increases the vascular resistance and all of that. So that's how it reduces your bleeding. They also noticed with octreotide, the rebleeding risk was about 23% compared to patients who were not on octreotide. And they checked this rebleeding risk at 1 year and 2 year intervals. The other drugs, and when I was asking some of the GI attendings if we actually use this or not, and they were saying that we do. Less common, but we do. These are some anti-angiogenics, so thalidomide, lenalidomide, and then Avastin. So this is basically a monoclonal antibody against your vascular endothelial growth factor. And it's actually a treatment for colorectal cancer, an approved treatment for colorectal cancer, but it can be used for lower GI bleed. Basically, you're just reducing the angiogenesis with these medications. And then, of course, if everything fails, you have surgery as the last resort.
So, Zainab, I have a question. How often are we using hormone therapy, like inpatient or outpatient?
Outpatient, when I do talk to some of the gastroenterologists here, they say, yes, we will have 1 or 2 patients that would come in like every 1 or 2 months that we do have on hormonal therapy. So yes, they're using it. But they were saying that this medication, the Avastin, it's more commonly used by hem-onc. For if they were to use it, the more commonly prescribed by hem-onc as an anti-angiogenesis marker. But yes, we do use it, and we have it here. So finally, some anticoagulation. This is the common question that whenever our patients start to bleed, the first thing comes to mind is just stop everything. You know, just stop whatever they were on for anticoagulation, and then most of the time we are asking GI, when do we resume it safely? When do you think we should resume it? And things like that. So I thought that this was helpful in terms of the guidelines that ACG recently gave. So any patient, and this is also going to talk about the reversal. So lower GI bleed, your patient is on warfarin, and let's say they're on warfarin for AFib, for stroke prevention. Do you give them vitamin K if they're having lower GI bleed? Irrespective, let's say, of the INR. Yeah, you're right, Mike, you don't. For GI bleeds, you do not give them vitamin K. And this is backed by the research that ACG took into account while giving those recommendations, that if you were to reverse them, and that would only be in a circumstance where they are having this life-threatening bleed with a substantially elevated INR, then you give them PCC versus an FFP, solely because the PCC is going to correct their INR faster as compared to the FFP. How low could you safely have your INR, or how low would you be safe, or how low would you want it before you were to consult GI for an endoscopy? What's their cutoff? 2.5. 2.5 is when they can safely perform any sort of procedures. For patients that are on DOACs, again, if it's a life-threatening bleed and they're not responding to fluids and all of that, then if you have those reversal agents available at your facility, definitely use them. The adarisizumab for dabigatran, and the adnexin alpha for the apixaban and rivaroxaban, that can be used. But for this also, the recommendation was do it if your patient has taken a DOAC within the past 24 hours. So not if they've already crossed that window of 24 hours. But as I said, this is conditional, life-threatening bleed, hemodynamically like significant bleeding. Platelet count, this is another common question. So a lot of like these, let's say patients that come in are sometimes cirrhotic as well. They have a lower platelet count. So the comfortable zone is for GI to do procedures is above 30,000 in severe bleeding and above 50,000 if they were to do an EGD. No benefit of doing a platelet transfusion for platelets for these patients. Lastly, they also talked about like aspirin. So we all know this, that if you're using, there's no recommendation of using aspirin for primary prevention. So just if for some reason they're on it, just discontinue when your patient is coming in with the GI bleed. If it is for secondary prevention, then aspirin, you initially hold it when they're coming in with the bleed, and you can resume it later once the bleeding has subsided. It has shown to have a higher rebleeding risk, but ACG does not recommend, of course, discontinuing aspirin when your patient has had a stent recently in the last 1 year. They do recommend that non-aspirin antiplatelets, that clopidogrel, they should be held in like severe hematochezia. And then again, this is conditional. If the stent has been less than 1 year, there should be a multidisciplinary team looking at those patients about when to safely resume this if they were to resume the dual therapy again. But they did not provide a specific answer to yes, do this and not do that. This would be a multidisciplinary case-by-case discussion for patients. They recommend against fibrinolytic agents like tranexamic acid solely because it did not show any benefit in lower GI bleeding if you were to use it. And then finally, the optimal time to resume anticoagulation after a GI bleed. They say it's not actually certain as to when, but typically you should resume it within 7 days after the bleeding episode. Depending, they've subsided, they're stable, you can resume it within 7 days so that you can reduce thromboembolic complications that are associated with you holding those medications.
Is that for antiplatelets as well?
Yeah. Yep. So the take-home points, as I said, use of risk stratification tools. I know we use these scores for a lot of like other things, but yes, do consider them when you're having a patient with lower GI bleed. The Oakland score, the data is, the ACG said in their presentation too that they still want a lot of more data to be implementing this on a national level, but so far through their score, through their data that they had, this was pretty good. It is backed by research, it is validated, so less than 8 in the ED, likely they would not benefit from an inpatient disadmission endoscopy or a colonoscopy. They could be doing it outpatient. And then lastly, if you have a patient that's hospitalized with a lower GI bleed that is requiring a colonoscopy, there is no benefit of you pushing for it in the first 24 hours versus 24 to 78 hours. The 78-hour mark is obviously going to carry a lower risk of rebleeding as compared to the initial within 24 hours. This depends on whether your patient is hemodynamically stable versus unstable. Colonoscopy is recommended for most patients with lower GI bleed, but if you have a normal colonoscopy and you've excluded colorectal cancer, always consider if you really want to get it done this admission when the bleeding has subsided. You already know that the patient has diverticulosis, then no point of repeating it this admission. Hemodynamically significant bleeding, discontinue the aspirin for primary prevention. You can continue it for secondary prevention. NSAIDs have to be discontinued. And then these are some of the medications that you can use to prevent rebleeding, which we discussed: iron, IV, oral, octreotide, hormonal therapy. They say that it is used, but it is not as effective as compared to octreotide. And then anti-angiogenic medications, which we discussed, the Avastin, these are also showing promise. We need more data prospective data for these because they have not been in the market that long. So I'll again come back to the case. So the same patient, does anybody want to read this or?
A 67-year-old female with, excuse me, coronary artery disease on aspirin and OA on chronic NSAIDs presents with stable bright red blood per rectum. Prior screening colonoscopy with good preparation 2 years ago with left-sided diverticulosis. She was hospitalized. She was hospitalized 6 months ago with severe hematochezia, stabilized with resuscitation. At that admission, colonoscopy 24 hours after presentation and bowel prep showed left-sided diverticulosis with blood throughout the colon with specific SRH, no intervention performed. The patient was discharged on the same regimen after spontaneous cessation of bleeding. At presentation for this encounter, the patient appears well and seems hemodynamically stable with 2-gram drop in hemoglobin from baseline. Question is, do we repeat colonoscopy? If so, when should we perform colonoscopy? And if not, do we consider CT, angiography, or other diagnostic testing? Is no testing a reasonable option? And then how do we minimize risk of recurrence?
Should we do a colonoscopy this admission? Yeah, so no. We do likely, in reality, yes, we do it. We do. If they have a 2 grams, I have personally called GI multiple times, hey, they dropped 2 grams in a day, let's just get something done. But looking at the data, they are not likely going to benefit if you've already ruled out colorectal neoplasia and things like that. Bleeding has subsided, patient is stable. They're not going to benefit from that colonoscopy this admission. Yes, outpatient for sure, but not this admission. And then I already talked about the timeline for the CT angiography. When should we do that? 20, yeah. Within 4 hours, hemodynamically significant lower GI bleeding only, not otherwise. No testing a reasonable option? Yes, 100%. And then minimize the risk of recurrence. So the medications that we talked about, hormonal therapy, octreotide, Avastin. So all of these discontinuing NSAIDs, aspirin only for secondary prevention, and things like that. And that is it. These are my references. And thanks to my mentors, Dr. Sharma and Dr. Jacob, for this presentation.
I would like to add about like a secondary prevention. If somebody is on dual antiplatelet and he presents with the GI bleed. So here, the scenario probably is going to change. Then we have to be cautious about like stopping antiplatelet. The reason is maybe the patient recently got the stenting procedure. So let's assume if the patient just had like a stenting procedure within a month or 2 months. So that's the area where we need to be cautious about stopping dual antiplatelet. So then we have to talk with the cardiology, we have to talk with the GI, making sure. So the guidelines usually says like if the patient is on dual antiplatelet within 3 months, so you can stop aspirin, but we have to continue opidovir. Okay. So, but the primary, we can stop aspirin.
All right, Dr. Abbasi, great job.